Good evening, everyone, and I'm honored to welcome you to this UROWebinar. This webinar has been organized by the European School of Urology and the EU section of Oncological Urology. We will explore the role of implementation of biomarkers and precision medicine in the therapeutic algorithm of localized, locally advanced, and metastatic prostate cancer. We have with us tonight three key opinion leaders who will discuss how to apply biomarkers in the clinical decision-making process, how to guide treatment intensity, and to evaluate the impact of precision strategies on patient outcomes. We aim to demonstrate how these tools can help personalize care, reduce overtreatment, and improve survival in prostate cancer patients. We will also discuss how to implement novel biomarkers and precision medicine in your daily routine clinical practice. With this, I'm pleased to introduce the three speakers of today. We have Dr. Tamás Fazekas from Budapest, Dr. Spratt from Case Western Reserve University in Cleveland, Ohio, and Dr. Bernard-Tessier from Villeneuve in France. Thank you very much for being with us tonight, and I'd like to ask Dr. Fazekas to start this webinar with the first lecture on how should we implement biomarkers in the decision-making process for localized prostate cancer. Thanks. The floor is yours.
Professor Gandaglia, thank you for this kind introduction. So today we are going to talk about how should we implement biomarkers in the decision-making process for localized prostate cancer. My name is Tamás Fazekas, and I'm a urologist at the Department of Urology at Szemeves University in Budapest, Hungary, and I'm a senior researcher associate in the Medical University of Vienna. I've got no conflict of interest. So first of all, we should ask the question that why do we need biomarkers at all? We know that prostate cancer and probably most tumors are highly heterogeneous, and as physicians, we would like to be able to tell the prognosis of a patient, moreover, how well he will do on a certain treatment or intervention. And to do so, we need biomarkers which can guide therapy optimization tailored to the patient's needs and the biology of their disease. And of course, our ultimate aim is to avoid under and over treatment. Now, let's see, for example, in the case of prostate cancer, we have the well-established trio of prognostic parameters, the T stage, which is notably still based on DRE, PSA level, and tumor grade. And with the use of these parameters, we are able to stratify the patients to risk categories, which can help us to select treatment. For low risk patients, active surveillance is standard of care now. However, when we arrive to the intermediate risk group, we have many more treatment options, and it's getting more complicated, from active surveillance to radical prostatectomy, radiotherapy, with or without ADT, not to mention treatment intensification, adjuvant TDT. So in this presentation, I'm going to talk about novel biomarkers which can guide treatment selection. And to start with, it's really important to highlight that the real value of these biomarkers depends on its ability to impact the course of the disease. We should keep this in mind. So basically, we have two main types of biomarkers, prognostic and predictive. A prognostic biomarker is used to identify the likelihood of a clinical event, for example, disease recurrence or progression in patients who have the disease or a medical condition of interest. And the other type of biomarker is the predictive, with which we can identify patients who are more likely to experience a favorable or unfavorable effect from exposure to a drug or an intervention. Notably, there are many prognostic, but not so many predictive markers. Generally, it's much harder to prove the predictive capability of a marker. And now let's see some examples from prostate cancer. Biomarkers can be molecular, such as PSA, or genetic, for example, genomic classifiers. We'll talk about them later on during this presentation. And they can be single gene mutations, for example, germline mutations with the BRCA1, 2, or ATM genes. There can be imaging-based biomarkers, MRI or PSMA PET-based, BI-RADS, different radiomic characteristics. And last but not least, There are many histopathological biomarkers. Probably the most well-known is the Gleason score, but we can talk about specific features, query for pattern, intraductal carcinoma. And recently, all of these markers have been or could be integrated into artificial intelligence-based risk models and tools with which we hope to outperform our previous risk predictions. So let's start with genomic classifiers. These are, all of them are RNA-based gene expression panels, and all of them are prognostic. We need tissue samples for all tests, which can origin from prostate biopsy for all the tests, or radical prostatectomy for some of them. After RNA isonation, these tests assess genes involved in different biological pathways associated with prostate cancer recurrence and metastatic potential. For example, cellular differentiation, organization, adhesion, cell motility, cell cycle, proliferation, angiotensin signaling, immune modulation, and stromal response. And then these results of the RNA sequencing, RNA expression analysis are quantified into numeric variables. Here you can see the numeric outputs of the different tests. And the higher values suggest a more aggressive disease. So all of them are really, really strongly prognostic markers. And currently, we can utilize them during active surveillance for active patient selection or adjuvant therapy selection after curative intent. Now let's see a clinical scenario. We've got a 64-year-old guy from Hungary with like general comorbidities, diabetes, hypertonia, family history negative, PSA of 5.4 nanogram per milliliters, a T2B disease on DRE, Pyrex 5 in the right lobe on the MRI, and we took a prostate biopsy from this patient, and it turns out that he had an ISUP2 disease, so he is in the EAU favorable intermediate risk category. Now we would be able to use these genomic classifiers. So let's see one by one. The strongest prognostic biomarker of all three is the Decipher. It can be the RNA sequencing can be performed based on biopsy or radical prostatectomy specimen, and the genomic classifier score ranging from 0 to 1 is calculated. It's a really strong predictor of biochemical recurrence, metastasis-free survival, cancer-specific survival, and adverse pathology. So it can help us in risk stratification for these patients. I brought you another retrospective publication of more than 100 patients on active surveillance. And in this analysis, a higher GC score was associated with a higher risk for biopsy upgrading. But there are more than hundreds of publications on all these genomic classifiers, so I try to be as concise and narrow as possible. Let's talk about Oncotype DX, which is another genomic classifier. Until recently, it was mainly used on biopsy specimens. Recently, there are some studies assessing it on radical prostatectomy tissues, and its output is the genomic prostate score, the GPS, which ranges from 0 to 100. And it's also a strong prognosticator of adverse pathology upon radical prostatectomy and long-term biochemical recurrence, distant metastasis, and the prostate cancer-specific mortality. Our third classifier is Prolaris, which can be measured both on biopsy and radical prostatectomy specimens. Its output is the cell cycle progression score, and it can be combined with this clinical risk stratification score, the CAPRA score, and then we will get the clinical cell cycle risk score, which can improve the prognostic accuracy over the use of CAPRA or cell cycle progression score alone. It's a really strong prognosticator of biochemical recurrence, metastasis-free survival, and cancer-specific survival. These genomic classifiers are mainly used in the United States, and there are various studies showing the effect of the real-world utilization of these tests. For example, here is a study by Zaworski and colleagues. It's a SEER-based study of almost 9,000 patients, and they have shown that the uptake of active surveillance or watchful waiting was higher among patients tested with or measured with genomic classifier. And interestingly, for NCCN low or favorable intermediate risk disease patients, had a higher genomic, the higher genomic classifier scores were associated with higher likelihood of local treatment selection. And there is another study with Polaris. It's a prospective registry of more than 1,000 patients. And they have shown that in almost 50% of the cases, it altered the treatment decisions with 72% treatment reduction and 27% treatment intensification. So these are really compelling real-world data on these genomic classifiers. But we should note that these tests have serious limitations, and the cost effectiveness of them outside of the United States is really questionable. It depends on the different healthcare systems and the reimbursements. They have been shown to be cost effective in the United States, but we cannot extrapolate these data to the European Union. And notably, most of these biomarkers were tested on large retrospective trials, and only a minority has been tested on randomized controlled trials or prospective trials. So the current EAU guidelines recommend or suggest that while it acknowledges that these tests are really promising and they have strong prognostic capabilities, they should be reserved for patients with EAU favorable intermediate risk for active surveillance selection in selected cases. Now let's see MRI as a prognostic biomarker. Well, it's out of question that MRI revolutionized prostate cancer detection, and we know that the higher PIRATE scores are associated with higher likelihood of clinically significant prostate cancer. But the question is that, is it associated with more aggressive disease as well? I brought you a study by Weber and colleagues who assessed almost 1,500 patients with pre-prostatectomy MRI and clinically significant prostate cancer on prostatectomy. And they have found that MRI visible lesions were associated with a higher rate of biochemical recurrence and metastasis at 15 years compared to MRI equivocal or MRI occult lesions. So visible lesions has worse long-term oncologic outcomes. There is another study, a systematic review and meta-analysis by RIVA, with comprising altogether more than 1,200 patients, mainly treated with radical prostatectomy, and they have shown that the PIRATE score was significantly associated with biochemical recurrence after curative treatment with a pooled hazard ratio of 3.19. Now let's see what's going on with active surveillance. This analysis was based on the PRIAS cohort, the largest active surveillance cohort today, and they developed and externally validated a prediction model to predict lesion grade group 2 reclassifications. And they have found that MRI visibility, so if there was suspicion lesion on MRI examination, was an independent predictor of grade group 2 reclassification. Now, let's say a few words about radiomics, which is a really emerging field in radiology. In this study of Suhanchev and colleagues assessed or they developed a machine learning model based on different radiomic characteristics on 64 patients on active surveillance, and their primary outcome was histopathological progression. And interestingly, at a median follow-up of almost 3 years, they found no difference in terms of AUC between precise score and the different machine learning predictive models. Now, we could ask the question that we have seen what genomic classifiers can do and what MRI can do, but are they contributing independent or overlapping prognostic information? We performed a systematic review on this topic, and we found that obviously MRI visibility has the genetic hallmarks of aggressive disease. So if we can see the disease on MRI, it's going to be more aggressive. We have seen on the retrospective series, and we have seen it in the meta-analysis. And interestingly, in the low and intermediate risk group, Oncotype DX and Polaris had weak or no correlation with PIRATES. And among PIRATES categories of low and intermediate risk tumors, the gene expressions were very heterogeneous. leading to the conclusion that genomic classifiers provide independent and complementary diagnostic and prognostic information, distinct from MRI for low and intermediate risk prostate cancer patients. Now let's see an artificial intelligence tool, the ARTER AI. I'm really happy that Professor Spratt is going to be our next presenter. It was his publication in New England Journal of Medicine. So they developed a machine learning model based on 4 phase 3 RCTs comparing different types of radiotherapy with radiotherapy plus ADT. And for this, they use the digital pathology slides on the biopsy specimen and clinical variables, and they validated this model on another phase 3 trial, which compared radiotherapy with radiotherapy plus 4 months ADT in mainly intermediate risk prostate cancer patients. And at a median follow-up of 15 years, they have found that 1/3 of all patients were model positive, who were supposed to have benefit from ADT, and 2/3 were model negative. And they found that the model positive patients had a lower risk of distant metastasis, and while in the model negative ones, they did not find this. And they found the similar results for prostate cancer specific mortality. So 1/3 of the patients, the model positives, ADT reduced the risk of prostate cancer specific survival, while ADT had no benefit in 2/3 of the patients. So it means that this biomarker risk stratification tool is predictive and prognostic at the same time, and it's recommended by NCCN guidelines for patient selection. Now, a few words really fast about the BRCA mutations and germline mutations. We know that BRCA germline mutations lead to a more aggressive disease with inferior oncologic outcomes for curative treatment. And the question is that, can we use active surveillance for these patients, or should we intensify treatment for them? Let's see our second clinical scenario. 52-year manager from Hungary with hypertonia, with a family history of breast, ovarian cancer on his mother's side, and his brother had prostate cancer. He's sexually active, PSA of 7, DRE not suspect, Pirates 4 in the left lobe, 3+3 disease, low risk, EAU low risk disease. He underwent genetic testing due to the family history, and it turned out that he had BRCA mutation. So what can we tell this patient? Well, fortunately, we have not so high quality data, but we have got some data on active surveillance for patients with BRCA mutations, like these 1,200 patients from Johns Hopkins and North Shore universities. They found 26 BRCA 1, 2, or ATM mutated patients, mainly grade group 1 disease, and they have found that those who had BRCA2 mutations and underwent anti-active surveillance, they had a higher risk for upgrading during follow-up, and they had an even higher risk for upgrading to I-3 disease. So it means that BRCA patients could be followed and active surveillance could be utilized, but stringent follow-up for patients for these genetically altered patients is needed. So as an overview, we have some take-home message. First of all, we talked about genomic classifiers. We have seen that they are strong prognosticators. However, they should be used only in selected cases based on the EAU recommendations for favorable intermediate risk patient selection during active surveillance, and maybe for unfavorable intermediate risk patients who are candidates for radiotherapy and ADT. Second, we have seen MRI. Pirates is thought to be prognostic. However, further research is warranted. It's not currently implemented in most risk stratification tools, but we should keep in mind that it has shown to be prognostic in many, mainly retrospective studies. We have seen an artificial intelligence tool, the ARTER AI, which is a powerful prognostic and predictive tool. It's currently not recommended by EAU, but it's recommended by NCCN. And BRCA has been a really hot topic in the past few years. Active surveillance is not contraindicated, but notably shorter biopsy intervals, MRI use, and early trigger for treatment should be made for these patients. So I would like to close my presentations and thank you for your attention.
Thank you very much, Tamas. It was an excellent presentation and a great overview. Now I'd like to invite Dr. Spratt to switch to the next chapter, which is the role of novel biomarkers in identifying patients with locally advanced prostate cancer. And we will focus on treatment intensification versus the intensification. Thank you.
Thank you so much. Thank you for having me. It's truly a pleasure to speak alongside so many experts. So yeah, moving along now from localized to kind of locally advanced disease. These are my disclosures. I don't receive any funding from any of the biomarker companies, but I do conduct a variety of clinical trials, some of which incorporate these biomarkers into them. So, we all know, and obviously I'm taking this a little bit from the US bias, and so NCCN guidelines for us and the NCCN risk groups, which are, very comparable to the different classifications around the world. But, this is the core elements that define our NCCN risk groups, the Gleason score, PSA, and, some definition of the extension of tumor, the T stage. I'd encourage people, I think you can get it for free. You just need to sign up. But there's an entire risk stratification section now in the NCCN guidelines, and they sort of define these three categories. Because as the last speaker said, there's many, many different tools we can use. And so we sort of define them as standard tools. These are your tools that can help you to assign, low, intermediate, high risk, which would be your PSA, your grade group, your TNM stage, and then for us, we use the percent positive cores involved because that's prognostic to help us distribute or define favorable and unfavorable intermediate risk. The additional clinical pathologic tools are really derivatives of these things, right? So for example, PSA, you can use this not just for the absolute PSA, but the PSA density, which is very prognostic, especially in lower risk disease, the PSA velocity, increasingly the data on absolute or percentage pattern 4 for grade group 2 and 3 disease. The last speaker talked about some histologic variants like cribiform and introductal patterns, and then some, absolute millimeters of cancer, etc. So these are things that can complement. Many of these have, we'll say, smaller retrospective data. Some of them are prognostic on multivariable analysis, some are not, but they do add some additional prognostic information, and effectively, these are free because you've already obtained them here if your center reports them. But this advanced tools is really what I'll mainly be focusing on is these, typically these are tests above and beyond what you would normally get. And so the main categories in general, we are talking about those gene expression tests. Increasingly right now, the Artera AI is based upon digital pathology. There's numerous companies rapidly entering the space with similar types of models, and then germline or somatic testing. So in general, right, as you nicely heard, almost all of our standard tools, whether they're the PSA or Gleason score, or these these additional clinical pathologic tools, these are prognostic, but they are not predictive. They don't tell you should you have surgery versus radiation, should you have hormones or no hormone therapy, etc. We are now finally starting to emerge with, I'll say preliminarily, some predictive biomarkers, and I'll be talking about that really I think will be practice changing. So in locally advanced prostate cancer, I'm kind of focusing on high risk, very high risk, and node positive disease. Now the NCCN guidelines, we call very high risk the same thing as the definition used in the Stampedes trial as high risk. And so for me as a radiation oncologist, and for many of our therapeutic questions, we're really talking about, do we need to be giving all men long-term hormone therapy, 18 months, 2 years of hormone therapy, which, as many of you know, is a major unwanted therapy for men, especially long-term. And should we be intensifying therapy, adding things like abiraterone for patients with the STAMPEDE high risk or node positive disease. But all of these decisions in current state are based on prognosis. And so if you've got a very favorable outcome, we often don't intensify. But they are not based on prediction or predictive biomarkers. So the advanced tools, just kind of put them in groups here. We have, different genetic testing. There was a question, almost always in this disease state, it's just germline testing. We don't typically, at least in the United States, perform somatic testing unless you have metastatic, truly distant metastatic disease. So usually this is just of the germline. And we often talk about DNA repair defects. The gene expression testing, so now in the NCCN, we are increasingly focused on tests with strong levels of evidence, which Decipher is the only one with sort of, while post hoc, it's been tested, as I'll show you, in numerous randomized trials. There's some other ones with less data that I'll speak about. Won't have time to talk about each of these, but some of these are, for example, PAM50 is being validated and will report out actually at the end of this month at our national meeting at ASTRO as the first gene expression biomarker to be tested prospectively in a randomized trial, and then some different digital pathology models. So this is sort of an area that I think is, for a while, we all assumed, I think you could see from some of the papers from the last speaker, it's sort of been indoctrinated in a lot of our minds that having a BRCA mutation or ATM, it means it's a more aggressive, clinical course. And that is very true for patients with advanced prostate cancer, definitely metastatic castrate-resistant prostate cancer. They have very clearly worse outcomes. But the question is, it hasn't really been answered well in early stage or localized disease, because the study by Dr. Castro that was shown, it was a very small number of patients with non-metastatic disease, and they really didn't perform a robust multivariable analysis to adjust for the clear differences in patients' clinical and pathologic factors. And to sort of give an example in that study, it was almost half of patients with quote unquote localized prostate cancer died in the first 5 to 8 years, which is just unheard of in any cohort. And so some larger studies now are finally coming out as we're starting to ask, are these all driver mutations, or can some of these just be passenger mutations? And so this is the largest study ever done, came out earlier this year. And what you see here, and it pooled together cohorts from Dana-Farber, Memorial Sloan Kettering, other centers, and so still very large. And on an unadjusted or adjusted, regardless if it's BRCA2 or some of these other mutations, the hazard ratio is always effectively less than 1. So if anything, they all cross 1, so none of these are significant. So they conclude in non-metastatic disease, there is no difference in prognosis. Some of these trend for more favorable, if anything, but there's no difference in prognosis whether you have one of these alterations or not. This is for metastasis-free survival. Another study, again, most of these are very small, but this was a prospective clinical trial done of neoadjuvant therapy before prostatectomy for intermediate and high-risk patients. And what you see here in a prospective trial, again, only 19 patients had DNA damage repair mutations, but the difference in recurrence after surgery was identical, whether you had one of these alterations or not. And this is much more in keeping, right? We don't believe, from the study from Castro, we don't believe that 5 or 8 years, half of our patients will be dead with localized disease. And so there's probably some selection bias in there. Now, moving on to gene expression testing, as I said, really the only ones that are really discussed now for treatment implications in the NCCN guidelines is Decipher. Prolaris and GPS, not anymore. GPS is the new name for Oncotype, and the main reason is just these are really pure institutional or registry type data, and there actually was a couple clinical or prospective studies with the Oncotype that actually showed they were not statistically significant. They didn't seem to pan out. So as you saw here, these are sort of the two main ones that discuss treatment implications in our guidelines. Decipher and Artera, they both give basically a continuous score and prediction for the risk of developing metastatic disease or death from prostate cancer. They have been very, very robustly validated in, importantly, post hoc randomized trials. So in localized disease, a whole bunch of radiotherapy randomized trials, Stampede, post-operative trials, including from the SAKK group and the RTOG, and even in advanced metastatic and prostate cancer. And so this, I think, is plenty of data, or at least we believe, to show that these tests are prognostic. What I don't think this necessarily is sufficient is to show something's predictive, because again, the last thing you want to do is to change someone's management if they've got an aggressive prognosis, because you believe something can truly predict if, let's say, you should give them hormone therapy or not. And so the level of validation needed, in my mind, for predictive biomarkers is much stronger. So then going into these treatment questions, so how do we use these to guide, short-term versus long-term hormone therapy? So first, with Decipher, these are 3 randomized trials in high-risk disease that many men got long-term hormone therapy, some got short-term. And what you see here is, again, this is prognostic, not predictive, is that if you have a low Decipher score, so that means you have a more favorable prognosis, the benefit to the man of extending from 4 months all the way to, over 2 years of hormone therapy is only 3% reduction in distant mets at 10 years. So that means a number needed to treat of 33. So you got to treat 33 guys with long-term hormones to reduce one guy from having distant met at 10 years. Surveys we've done and others is that this is probably below the threshold that most men will be willing to take long-term hormone therapy for, and that actually includes experts. We surveyed urologists and radiation oncologists and medical oncologists, and most of them said they'd want closer. Some said 3%, many said they'd want at least 5% benefit to do this. But if you have Decipher high, it's an 11% benefit. So that means a number needed to treat of 9. So less than 10 guys you need to treat. So this is a big benefit. So this alone lets you use prognosis to help have these shared decision-making conversations. But as I said, to really have level 1A evidence, you need this in a randomized trial. So this is called the PREDICT-RT trial, or the NRG-G009 trial. It's over 2,000 men in high-risk prostate cancer. It's basically 2 randomized trials. One is a lower Decipher, lower intermediate Decipher, and it's trying to test, can we shorten hormone therapy from 24 months down to just 12 months? The other is for the ultra-high Decipher scores. Is this the group that actually benefits from adding an ARPI like Abi or apalutamide? These are both completed accrual, and so we await the results of this study. Now, the Artera test, the MMAI test, has done sort of similar studies. It's a little different because it is newer test, but again, profiled, it's a lot cheaper and easier to profile digital pathology than it is to extract tissue. You need a lot more tissue for genomic analysis. And what you see here is they have not yet reported the number needed to treat, or how did patients do based on the Artera score with short-term versus long-term. But what they did do is they said, well, if you pool all these high-risk patients together, the vast majority got long-term hormone therapy. If you have an Artera low score, no men develop METs at 5 years and only 3% did at 10 years. But if you're intermediate or high score, very high rates of metastasis. So kind of the same concept. You can imagine that, going to short-term hormone therapy, probably there's a small but potential benefit of doing long-term hormones, but that benefit's going to be far greater if you have a higher Artera score. And so then we get into, there's a lot of controversy right now in the States because, the STAMPEDE trial, which is the only trial in this subset analysis, shows potentially the benefit of abiraterone. But really, should we be doing this for all of these patients? And so for those not familiar with the study by Attard et al., right, so this was a trial of patients that were metastatic and non-metastatic. And so they took the subset that was not metastatic. They pooled it, 2 different treatments together, abiraterone and one added enzalutamide. And then they further looked at the subset that the nodal involvement was not present. But these are not, at least what we see, these are not our normal locally advanced patients, right? This is all conventional imaging. But, these guys had PSAs over 1,000, some of them. I don't think I've ever seen a patient with a PSA over, a few hundred that doesn't have distant metastatic disease. So this is a very unique population with very aggressive outcomes. But despite this, they've shown, this is the Decipher data just published in Cell, that you can see that if you've got a Decipher less than about 0.85 is kind of what it comes out to. So there really is no benefit of adding abiraterone. So this is kind of what's the improvement in metastasis-free survival over time from adding abiraterone. It's about 1%. So that means you got to treat 100 guys to benefit 1. And remember, abiraterone has a lot of costs as well as toxicity, versus if you've got that ultra high Decipher, it's about a number needed to treat a 5. The same thing was in a presentation at ASCO last year. It's also been published. Similarly, if you've got, the majority of men on STAMPEDE had a lower Artera score, about 1% or 2% of benefit of abiraterone. But if you had a very high Artera score, similarly, a large benefit. I urge people, to kind of wait still, though, before adopting abiraterone in this setting, because we still don't have results of Enzarad, Atlas, or Dazzle HiCap. And I'm not sure with especially PSMA staging, but that these will, I don't think these will replicate the results of STAMPEDE, given how unique the population is. And to just touch on one other test, one of the things about the Decipher test is, yes, it tests those 22 genes, but it also tests effectively the whole transcriptome. And so you can get numerous signatures, but one of the most relevant is these molecular subtypes, luminal A, luminal B, and basal. And so these, we talk about these often in breast cancer, but they exist in prostate cancer. And so this is the trial I had mentioned. So we completed this trial in 2020, and so this primary endpoint we'll be reporting out at the end of this month at ASTRO in the US. It's embargoed. It's a late-breaking abstract, so I can't tell you the results, but it's the first biomarker stratified trial. So it's actually designed prospectively to test, are luminal B patients, do they benefit from adding hormone therapy to postoperative radiation? And I think it will be practice changing, but I'm biased. But yeah, I think you'll all see the results and be very excited soon. And so kind of just in summary here, some of these tests here, I didn't have time to go over all of them, but all of these have different levels of training and validation. All of them have been validated in post hoc randomized trials, but really the highest bar in prospective randomized trials. Decipher has completed 2 big trials. We await results. Artera does not have any yet. I believe some are planned, but that will take some time. As I said, PAM50 will be the first actually ever to report out in a few weeks. So thank you guys again so much for the opportunity to speak today.
Thank you, and it was an excellent overview. And with this, I'd like to ask our last speaker for tonight, Dr. Bernard-Tessier, to present on how precision medicine improves survival in metastatic prostate cancer. Thank you.
So thank you for this invitation. I'm Alice Bernard. I'm a GU oncologist at Gustave Roussy, France, but also currently a visitor scientist in Misha Bertrand lab in Dana-Farber. So I'm pretty sure I don't need to convince you that precision medicine improves survival in metastatic prostate cancer. So I would rather focus my talk on how precision how precision medicine improves survival in metastatic prostate cancer. This is my conflict of interest. So first of all, we discussed it with the previous talk, but we have currently many tools to use for prognostication and developing targeted therapy. But most of it are prognostic biomarkers. We have, from one hand, archived prostate tumor samples. It's easy to have, it's easy to analyze, but it's not fully relevant for studying mCRPC drivers. On the other hand, we have metastatic biopsy, but most of our patients are metastatic to the bone, and we know that the analysis can be tricky for bone for genomic and transcriptomic analysis. So the most used tool can be plasma, ctDNA, circulating tumor DNA, which is able to capture the genomic alteration at one time point. And finally, imaging-based biomarker are emerging as a powerful tool for stratification and predictive use. So we can use all these great techniques, but if we don't use it at good time, we miss the spots. So because of the heterogeneity of the tumor at metastatic sample and mainly in prostate castration-resistant prostate cancer, but also because the emergence of molecular alteration associated with treatment resistance. So that's my first message, key home message, that precision medicine can improve survival with the right tool at the right time. So let's now deep dive into the biomarker we have. And I mainly focus on mCRPC setting because most of the studies have been done in this setting, even though that it's now the knowledge in hormone-sensitive setting is going deeper. We can now, for many years, we have now the knowledge that we can divide mCRPC into different subtypes according to different molecular alteration with their own prognostic biomarkers and the potential targeted therapy. So I've selected some examples to present to you, like AR pathway, DNA repair deficiency, MSI, PTEN loss, and obviously PSMA. And first, I'll start where precision medicine does not improve survival, in hormone-sensitive setting and mCRPC. We know that AR pathway is the driver of prostate cancer progression. But unfortunately, in hormone-sensitive setting, despite the intensification with ARPI, we have still some patients, quite low, 10%, who are not responding well to the combination of ADT plus ARPI. And currently, we don't have any biomarker to select patients and improve the stratification and the intensification for this patient. As Daniel Spratt showed us, the STAMPEDE trial has shown recently that the CFR test, so a transcriptomic test, can maybe select patients for the Cetaxel intensification, and maybe Pathomics will help us to improve the selection for patients and able to select this patient. From the mCRPC setting, it's completely another story. We have biomarkers. We know that during the hormone treatment selection pressure, we have emergence of AR alteration. We have AR splicing variants, AR amplification, and AR mutation. And all these alterations are associated with worse outcomes. Right now, we don't have targeted therapy, but phase 3 trials are ongoing to test third-generation AR-targeted therapy for patients with AR mutation. So maybe in a couple of years, I will be able to show you that we have improved survival in AR biomarker selected population. So the most important biomarker we currently have in metastatic prostate cancer is BRCA and DNA repair deficiency. As it has been shown, indeed, BRCA alteration is a strong prognosis biomarker in different settings, and mostly in metastatic setting with hormone-sensitive setting and mCRPC setting. And BRCA and DNA repair deficiency is also associated with response to PARP inhibitor. So it's a strong predictive biomarker for PARP inhibitor in prostate cancer. You have on your left olaparib showing a benefit in overall survival in patients with mCRPC pre-treated with taxane and with BRCA alteration. And on your right, you have rucaparib, who showed a benefit in progression-free survival in patients compared to docetaxel. But unfortunately, probably due to the crossover and that the fact that overall survival was a secondary endpoint, we haven't shown a benefit in overall survival of rucaparib in BRCA population. And that's my second key message, that trial design matters to show the survival benefits. And it's more obvious in the design of trial testing the combination of PARP inhibitors plus ARPI. In 2 out of 3 trials testing, so PARP inhibitor plus ARPI, the intended to treat population was all comers, unselected population. So indeed, we have an improvement in overall survival of the combination. And if we look into the biomarker, the benefit is driven by homologous recombination repair mutation. And if we look into the HRR mutation, not all mutations are equal. And the benefit is mainly driven by BRCA2 and CDK12 alteration. So hopefully now we have the PARP inhibitors, the result of PARP inhibitors in hormone-sensitive settings, the result of Amplitude trial presented at ASCO this year. And as you can see, we still have the benefit driven by BRCA alteration. But beyond DNA repair deficiency, MSI high phenotype is also a very good predictive biomarker. Despite all the negative trials of immune checkpoint inhibitors in prostate cancer, we know that whatever the tumor, MSI high is predictive of response to immune checkpoint inhibitors. And we know also that MSI high tumors in mCRPC setting is associated with the very worst prognosis. And as you can see here, we have only retrospective cohorts, but you can improve overall survival with the median overall survival of 27 months with patients with MSI high tumors, prostate tumors, treated with immune checkpoint, mainly anti-PD-1 and anti-PD-L1 in the mCRPC setting. So we have to think about it because it's rare, about 3% of the population. And it's easy to test. It's just testing the archive tumor sample for IHC. And when it's positive, we should consider immune checkpoint inhibitors. And speaking about archive tumor samples, I would like also to show you another example of failure in precision medicine. Here, you have a KIT inhibitor combined with abiraterone in mCRPC tumor with a PTEN loss defined by IHC on archive tumor samples. And as you can see on the left, you can see that abiraterone plus ipatasertib does not improve progression-free survival in combination compared to abiraterone alone in PTEN loss defined by IHC testing. But if you look at the assessment of PTEN based on the sequencing, genome sequencing by next generation sequencing, the addition of ipatasertib improves survival. So that means that we can have a good tool, but if we can have a good target, but if we're not using the good tool, we can miss the improvement in overall survival. And finally, genomic alteration are trendy, but imaging-based biomarkers are more easy to use. And we know that PSMA PET positivity predicts response to lutetium PSMA in monotherapy or in combination with ARPI. So unfortunately, right now, we don't have more granularity than just positive versus negative for PET PSMA. We know that SUV mean is predictive of response to lutetium PSMA, but we know it's a prognosis, but it's not currently predictive. And maybe in the future, we'll have a various PET scan to enable to select correctly a patient in metastatic setting. So my question, has precision medicine improved survival in metastatic prostate cancer? I can say loudly that yes, but we still have barriers to implementation of precision medicine in prostate cancer. As I've shown you, we have to define the good biomarker. Depending on the setting and the timing, we have ctDNA versus biopsy. And for sure, we have shown you that depending on the design of your trial, you can miss the improvement in overall survival. And indeed, in some industry trials, it's unselected population. That's why we need academic trials to propose clever design to select population which are able to benefit mostly of the targeted therapy. And it's wonderful to have good precision medicine, but we need reimbursement for our patients. And I just want to remind you that in France, for example, BRCA testing is not fully reimbursed for a patient with metastatic disease, despite the benefit we have in the setting of PARP inhibitor. So I'll finish my talk on this adaptive biomarker-driven platform trials. On your left, you have P6 program. And as you can see, we stratify patients with the old biomarker, PSA. Indeed, it's a good one, but we need to improve our selection. And I hope in the future, we'll be able to put more next generation biomarkers in this program. And on the right, you have PREDICT trial, which is a phase 2 trial with very, very next generation biomarkers like ctDNA, RNA-seq, and new targeted therapy. But unfortunately, this is phase 2 trial, and we know that it's quite difficult to show the improvement in survival with, and mostly in overall survival with the phase 2 trial. So we have still to work on the academic way to prove that precision medicine can improve overall survival in metastatic prostate cancer. Thank you for the attention. I'm happy to take questions.
Thank you very much, and it was a great evening and great discussion, or great presentations actually. Now it's time for discussion. So we had a couple of questions in the chat. One is related to the use of urinary biomarkers, and I'd like to ask Dr. Spratt to answer to the potential role of biomarkers in the setting of urinary biomarkers in the setting of locally advanced disease.
Yeah, so urine biomarkers, I guess the question is, are you guys using urine biomarkers at any stage of prostate cancer? To any of the other panel members?
But we did, but it's not so common anymore. They are not reimbursed, and no. The short answer is no.
Okay.
Yeah, same with us. So it's not reimbursed. There's an opportunity to use them in private practice, but I think since MRI, then we don't really use it. So
yeah, I would say, you know, in general, yeah, these biomarkers were developed often pre-MRI or in series without MRIs, we'll put it that way, to try to identify or enrich for clinically significant prostate cancer. There has been some that have shown maybe it can add to MRI, but once you're diagnosed with prostate cancer, there really has not been robust evidence that this is going to be meaningfully helpful. So it's more so a lack of data. I would say that not in some of these tests, just so you know, you need to do a digital rectal exam, almost like a prostate massage. Some of them you don't. So yeah, in general, yeah, the short answer is no, we don't use these, and they also would not be covered in the United States. You'd have to pay out of pocket if you're already diagnosed with prostate cancer.
I think that once you have biological material from the biopsy or from the radical prostatectomy specimen, you have everything you need. You don't need to go back to the urine, even if you have a localized disease. And so thank you for your answer. And we have a question for Dr. Bernard on the role of assessing BRCA mutations to select patients for diagnostics or for PARP inhibitors after taxanes and PARP and ARPs. So, which is the role of, let's say, for subsequent sequential therapies, the role of these mutations?
That's a very good question. Should we do PARP inhibitor first lutetium? And because both are targeting DNA repair, lutetium is radiation, right? I would like to say if I was able to do it, it's combining both. We have now phase 2 trial showing the combination of PARP inhibitor plus lutetium. For this patient, I would like to do both together. But if I cannot for regulatory access, definitely I'll start first by PARP inhibitor.
Thank
because
you.
Addiction to PARP inhibitor and BRCA.
Thank you. And Dr. Fazekas, please. We see your hand.
Can I have a question, if possible, to Dr. Bernard? So thank you for this really nice talk. I would like to ask for your opinion about platinum treatment for BRCA-positive prostate cancer patients, because there is emerging, but not so high quality evidence, but there is something out there, mainly retrospective cohorts and some small phase 2 studies. So are BRCA mutations predictive for platinum treatment as well as PARP inhibitors?
So definitely, but we haven't compared carboplatin versus PARP inhibitors in all the tumors and prostate cancer, but also breast and ovarian cancer. So to be honest, I'm opening soon a P6 arm with carboplatin for BRCA patients, because we haven't access and we won't have access to PARP inhibitor in European country as soon as US for BRCA patient in a hormone sensitive setting. So definitely carboplatin is a good option when you don't have PARP inhibitor.
Thank you.
Thank you. And a general question for all speakers regarding the optimal timing of a biopsy or obtaining the biopsy material to test when we're talking about, for example, somatic mutations. So we know, and Dr. Bernard has been telling us that it's difficult to obtain biopsy from the bone metastasis. So for how long can we rely on our radical prostatectomy or prostate biopsy specimens, and which is the best way? And what is also the use of circulating tumor cells in your clinical practice? Because in Italy is still, let's say, something we do for clinical trials, but it's not really reimbursed and available for, let's say, clinical practice.
So I think that archive tumor samples should be tested because it's easier and we have to test it, but I don't rely on a negativity test, a negative test. I mean, if it's negative, I like to test it again, and ctDNA is good because you can do multiple samples. So we are lucky in Gustave Roussy because we have ctDNA for all patients, and we're trying to broadly put it propose it to all the French centers. But definitely ctDNA is really important for MCRPC setting. But data, well, we have multiple studies showing that as soon as you start ADT in hormone sensitive setting, UPSA is dropping, but ctDNA is dropping about 21 days, 3 weeks. So if you're not doing ctDNA as before starting ADT, you shouldn't do ctDNA unless you're MCRPC setting. So because we need BRCA testing as soon as we are thinking about it, so I think testing earlier is better. We should test first archive samples.
Dr. Spratt, comments on this?
Yeah, you know, I think that we prefer, when possible, if you have a metastatic biopsy, to do that for sequencing. I think that when that's not available, then we'll see what other tissue is available, right? So if there's a prostatectomy or something that's archived. We also, you know, if you have advanced metastatic prostate cancer, will do liquid biopsies routinely. And so it's sort of, I would say that that's not the preference. We'd rather have the tissue, but that's, as we've discussed, that's definitely not always available. I mean, I have a patient right now who is, CRPC. We've done metastatic directed therapy to maybe 4 areas. There's a new area, but it's on like a small area on the scapula. The yield will be very low. And so I think that you need to use, because, one of the, some people will say one of the biggest travesties is not giving a PARP or a platinum to someone with a BRCA2 mutation. They have such a massive, massive benefit. It is worth searching for when you have CRPC.
Thank you very much. And I think we have now to close this wonderful webinar, but I'd like to thank you for the high level of your presentations and of the discussion. Thank you again, and for all attendance, you can also find the registration of the webinar online on the YouTube channels, the EAU channels website, and everywhere. So thank you, have a good night, and goodbye.